I'm Dr. Ashis. So let's see our what is Barrett's esophagus. Let's see one case, clinical case over here. We have a patient who is 52 years old and presents to the emergency room with chest pain. Patient has a problem. He denies any pain with physical exertion. No pain with physical exertion. That means it's not the CVS pain. All right. He just had a large fatty spicy meal. His cardiac workup is negative. He has had GERD for the past 10 years. This point to be noted over here. And but recently developed increasing heartburn and regurgitation. All right. So patient has the heartburn with regurgitation and then the chest pain. We have to see these 3 points. All right. These 2 points over here and then 1 point over here. His BMI is 31 kg per meter square. The patient is obese. His emergency room physician recommends that he continue using proton pump inhibitors and schedules an outpatient primary care appointment for him. In a note to his PCP, primary care physicians, he suggests a screening endoscopy, right? And then his endoscopy finding is mentioned over here. So what we can see here in the endoscopy is that we can see this is one the dusky color epithelium, and then here we can see the tongue like, or we can see the velvet color of the epithelium, and these margins are irregular, we can see, right? So that we have the multiple islands of this the velvet or tongue color epithelium, which is irregular. We can see the dusky color epithelium in the middle, right? So this finding is typical for the Barrett's esophagus, right? Where we have this the dusky color, that is our squamous epithelium, which is of the normal lining of the esophagus. It is replaced by the columnar epithelium, right? So this is the typical finding in the Barrett's esophagus. And also the the cases in the question, the complaints of the patient is the heartburn with regurgitation plus chest pain, and patient has the gastroesophageal reflux for 10 years. Remember, if the patient had GERD for more than 5 years, patient develops the Barrett's esophagus, so that we have to go for the endoscopy. So this is also the question in the exam. Please remember this one. After this, let's go forward. What is GEJ? After knowing the GEJ, we can go for the definition of the Barrett's esophagus. For example, this is my esophagus. Let me draw the esophagus over here. In this esophagus, if you remember, this is my upper esophageal sphincter and this is my lower esophageal sphincter, right? So this is my upper esophageal sphincter. This is my lower esophageal sphincter. Upper esophageal sphincter is 4 to 5 centimeter long. Lower esophageal sphincter is about 3 to 5 centimeter long, right? And within this lower esophageal sphincter, we have some markings over here if we see inside. Okay, so within this lower esophageal sphincter, we have something lies over here and we have something lies over here. Okay, so this something, this is called the gastric rugal fold, and this red line I draw over here, this is called the SCJ, squamocolumnar junction. This squamocolumnar junction means the epithelial lining just below this, these are the columnar epithelium, and then the epithelial lining above this, these are the stratified squamous epithelium. Is that okay? So that this is the place where we have the junction between the squamous cell above and then the columnar cells below, right? So that this is called what? Squamocolumnar junction. So the distance between these two, where we have shown you the gastric rugal folds over here, this distance is about 3 millimeter to 10 millimeter. Is that okay? So this gastric rugal fold, from where it begins, this is exactly called as the gastroesophageal junction. This is anatomically. Is that okay? And this SCJ, from where we have the squamous cells and then the columnar cells, they separates, right? So this is squamo-columnar junction. This is also called ora serrata. This is also called what? Ora serrata. Or this is the squamo-columnar junction, from where the columnar epithelium of the stomach is separated from the squamous, stratified squamous epithelium of the esophagus. Is that okay? So that actually gastroesophageal junction, this one, the histologically or endoscopically, this is also called gastroesophageal junction, and this is also called gastroesophageal junction, but they have the differences insidiously. Is that okay? So that these two are the markings of the gastroesophageal junction. If we see endoscopically, sometimes we can see the gastroesophageal junction from outside as well. From the outside, we also see the two markings over here. Number one, we see the valve of Helvetus. What is valve of Helvetus? Valve of Helvetus means the esophagus has the circular smooth muscle. When it comes to the stomach, the circular smooth muscles are most inside, and then in the middle there are the oblique smooth muscles within the stomach, right? So this is the junction from where the circular smooth muscle is continuous with the oblique smooth muscle of the stomach. So this oblique smooth muscle, they forms the sling like this within the stomach and esophagus junction. So this is called what? Valve of Helvetus. What is this called? Valve of Helvetus. This is also called the loop of Willis. Is that okay? So this is the another marking from outside. From the outside, if we see, we have the another one more marking. That marking is just outside the esophagus. We have the diaphragm lying like this, and just below the diaphragm we have the fat pad present over here. This is my extra esophageal fat pad which is below the diaphragm. So this also marks the gastroesophageal junction inside. Is that okay? So that we have the four markings of the gastroesophageal junction. We need this gastroesophageal junction to define the Barrett's esophagus, right? So what are those four markings? Two of them are endoscopic markings, and two of them are marking from outside, right? So endoscopic marking is what? Number one, we see the squamo-columnar junction. Another one, we see the rugal folds. Is that okay? Rugal folds. From the outside, we have two things. One is the valve of Helvetus, and another one is what? That is extra esophageal fat pad. So these four things can differentiate the gastroesophageal junction. Is that okay? So once we know the gastroesophageal junction, it will be easy for us to define the Barrett's esophagus. Now we will go forward. Look at here in this picture, we can see over here. Here we have the squamo-columnar junction. Just below this we have what? The gastroesophageal junction, actual anatomical gastroesophageal junction, which is also called what? The rugal fold, the beginning of the rugal fold, right? So this is the beginning of the rugal fold. This is my what? The squamo-columnar junction, SCJ. Above this we have the squamous cell, below this we have the columnar cells. This is the endoscopic finding from inside. From outside, as we said, we have the fat pad over here, this fat pad. And then another one we said is what? The valve of Helvetus. We can see over here. These are the oblique muscles of the stomach. These are the circular muscles of the esophagus. So this junction between these two, this is called what? The collar of Helvetus or valve of Helvetus, or also known as the Willis, right? The loop of Willis. Is that okay? And insidiously, that is also called what? Ora serrata, which is this called the ora serrata. Ora serrata means the squamo-columnar junction. This is also called the Z line. What is this called? Z line. Is that okay? So it has the three names over there. So from there we differentiate. This is the gastroesophageal junction. Here we can see over here in this picture also we can see the separate margins, right? And we can see the fat pad from outside, right? So these are the findings over here. Now let's go to the definition of the Barrett's esophagus. For the definition of the Barrett's esophagus, I'd like to draw one picture like this. And in this picture, for example, this is my esophagus, and in this esophagus, as we said, we have the these are the rugal folds, right? So these are my rugal folds, and I have the SCJ present over here. Yes, and this is my which type of epithelium? Velvet color or tongue color, the simple columnar epithelium. And above this, what do we have? We have the dusky color squamous, stratified squamous epithelium lining of the esophagus. Yes. So what is Barrett's esophagus? The Barrett's esophagus, in the simple definition we can define, is that these squamous stratified squamous epithelium that should be replaced by simple columnar epithelium, right? So this is called what? Barrett's esophagus. This is the definition of the Barrett's esophagus. And this Barrett's esophagus was at first discovered by the scientist, the British scientist, in 1950 AD. His name was Barrett. That's why it is called what? The Barrett's esophagus. Hope you are clear, right? So this is the definition. So that we can go forward. As we discussed already, what is this distance? This distance should be, this distance is how much? 0.321 centimeter or 3 millimeter to 10 millimeter, right? So this is the distance between, this is my what? If you remember still, this is the GEJ, actual anatomical GEJ, and this is what? SCJ, squamo-columnar junction, or the jet line. Yes. Traditionally, it was defined. What was the traditional definition of the Barrett's esophagus? Traditionally, it was defined that the esophagus from the GEJ, above the GEJ, more than 3 centimeter of esophagus, right, should be replaced by columnar epithelium. That was the traditional definition, right? And this columnar epithelium can be intestinal type, this can be junctional type, right? Or this can be the gastric type, right? So any kind of columnar epithelium which replace the more than 3 centimeter of the length of the lower esophagus, that was called as what? The Barrett's esophagus traditionally. But in the modern definition, what we discussed is that in the modern definition, what they say, any length of the esophagus, any length of the esophagus that is replaced by what? What is this one? The columnar metaplasia. Any length. There is no marking, there is no, the margins of the 3 centimeter. Any length, if it is replaced by the columnar epithelium, that is called what? The Barrett's esophagus. This is the modern definition. Is that okay? Both of these should be confirmed by the endoscopy with biopsy. Then only we can say this is what? The Barrett's esophagus. So that is the definition of Barrett's esophagus. Is that okay? And another thing is that initially the Barrett's esophagus was thought to be only congenital. Why they thought that was the congenital? Because in the patient with Barrett's esophagus, when they do the biopsy, endoscopic biopsy, they found the gastric epithelium, ectopic, fundic means the fundus of the stomach, fundic epithelium in the upper half of the esophagus. That's why they considered this as the congenital problem. But later on, what happened, when they keep studying in the patients, the patient who has the GERD for more than 5 years, the patient with GERD for more than 5 years, 10 to 15% of the patient, they develops the Barrett's esophagus. That's why the concept of the Barrett's esophagus has been changed. So initially that was only thought it was the congenital problem. Why? The reason I told you right now. Okay. These are the things. The next things we have to know some facts over here. The patient with Barrett's esophagus, right? The 44% of the patient, let me clear this one, my handwriting is not clear, right? Barrett's esophagus patient, the 44%, they have the increased gastric HCl secretion. This is one fact. Another fact is that the patient who has the Barrett's esophagus, the chances of malignancy increase to 40 times. Another one, usually 1/3 of the Barrett's esophagus patient present with the malignancy. Present with what? Malignancy. Every year, about 0.223% of the patient with Barrett's esophagus, they develops the malignancy. Is that okay? So these are the facts we have to remember. And these malignancy is most commonly adenocarcinoma. This is the question in the exam. Okay, this is the adenocarcinoma. And usually the mean age of the Barrett's esophagus presentation is about 55 years, and then this is common in men than in women. Is that okay? That means the male patient is more common than the female patients. Is that okay? Mean age I said. And then white population is more affected than the black populations. Is that clear? So these are the facts about the Barrett's esophagus. Now let's see about the etiology of the Barrett's esophagus. In the etiology, we have to know that the first cause is what? Smoking, right? And then finally smoking increases what? GERD, and GERD finally causes what? The Barrett's esophagus when it is for more than 5 years. Show that. They can ask you in the exam, what is the most common cause of Barrett's esophagus? Answer should be GERD. Is that okay? So any other causes which causes the GERD can develop the Barrett's esophagus. Another one is what? The central obesity. In our question, if you remember, his BMI was 31 kg per meter square. Yes or no? So the central obesity increases the intra-abdominal pressure. That causes the regurgitation. That means it produces the GERD. Finally, GERD develops what? Barrett's esophagus. Similarly, the other causes can be all form of esophagitis, right? Esophagitis can be of any, maybe the infectious esophagitis, maybe the medication induced esophagitis, right? Or maybe the caustic injury related esophagitis, right? So any cause of the esophagitis, this esophagitis can lead to what? What is this one? The Barrett's esophagus. Is that okay? So that these are the causes or the etiology of the what is this one? The Barrett's esophagus. Now let's go to the pathophysiology. What is the pathophysiology of the Barrett's esophagus? Let's see over here. In the pathophysiology, we can discuss very easily. For example, we have the bile reflux or HCl reflux, or any cause of the esophageal mucosal injury, right? So anything that causes the lower esophageal mucosal injury, right? So finally the cause is what? Increase interleukin 1 or increase interleukin 8. Is that okay? These are the inflammatory cytokines. These interleukins, both of these interleukins, let's understand over here. This is also the question in the exam. These interleukins will cause the attraction of neutrophils and T lymphocytes. Is that okay? So that the neutrophils and T lymphocytes, when they are attracted, right? Neutrophil, hope you know, they are the polymorphonuclear cells, and these are the T lymphocytes, right? So anyway, they attract these kind of cells. These are the inflammatory cells. So this is one finding in the biopsy. This is a question they can ask you in the exam, right? So once this interleukin 1 and interleukin 8 is released, neutrophil and T lymphocytes are attracted. Once they do so, these interleukins, they begin to cause the superficial coagulative necrosis of the esophageal mucosa, right? So this is another finding, in the endoscopy or in the biopsy, we see what? The superficial coagulative necrosis. So this is another finding of the esophageal mucosa. Once it happens, this coagulations, necrosis, then these cells, they have to regenerate, right? So for the regeneration, they need the more blood flow. So if it need the more blood flow, if you remember, within the esophagus, this esophagus has the mucosa, and below the mucosa we have the submucosa, and within this mucosa we have the lamina propria. Lamina propria has lots of blood vessels, right? And this kind of foldings, these foldings are called what? Papilla. What are they called? Papilla. So this papilla becomes long. This papilla present where? This papilla present within the lamina propria. Why this papilla becomes long? Because we need to regenerate the surface epithelium over here. If we have to regenerate the surface epithelium over here, we need more blood flow. So for the more blood flow, this papilla becomes longer. Once the papilla becomes longer, these blood vessels also begin to proliferate larger. So new cells begin to form over here, and papilla becomes longer, elongated papilla. This is also another finding in the biopsy. This is the question in the exam. And because of the elongation of the papilla, what happens? Blood vessels increase blood vessel. This increased blood vessel produces what? Hyperemia. It produces what? Hyperemia. What is this called? Hyperemia. This is the increased vascularity. This hyperemia produced on this is also the finding in the endoscopy or the biopsy. Is that okay? So after that, what it does, this we have the bile acid over here, bile acid. This bile acid begins to stimulate the two genes, that is what? MUC2 gene, and then it also stimulates another gene that is called what? CDX2. This MUC2 gene, it begins to forms or transform the cells into what? Into the goblet cells. It forms what? Goblet cells. And then CDX2, they begin to form the columnar cells. They begin to form what? Columnar cells. So that this is another finding in the endoscopy, right? So goblet cells we can see, and then we can see what? The columnar cells within the injured epithelium. Is that okay? So these many findings we will see over here. And then one more thing I forgot to explain. That is what? This elongations of the papilla. This elongation of the papilla produces what? Hyperemia over here. And if hyperemia produces, new cells begin to grow. These cells needs the supplement. And because of the supplement of these new cells here within the lamina propria, the basal cell layers, the stem cell layers thickness will increase. What increases? Basal cell thickness will increase. This is our another finding. So what are the findings in case of this Barrett's esophagus pathophysiology? Let's see over here. Because of these things, they causes the injury. This injury causes the interleukin 1 and interleukin 8 release. This interleukin 1 and interleukin 8 begins to recruit the neutrophils and T lymphocytes, right? So these are the inflammatory cells recruitment. After that, it causes this superficial coagulative necrosis. This coagulative necrosis is also another finding. And because of this coagulative necrosis, what happens, this cell needs to undergo the renewal process. For the renewal process, these papillas in the lamina propria undergoes increase in length. If the length increases, blood vessels also increases. If the blood vessel increases, this looks hyperemic. And at the same time, for the supplement of the cells, the basal cell layers thickness should be increased. This is the findings, right? And at the same time, what happens? Bile acid stimulates the MUC2 gene and CDX2 gene. MUC2 gene begin to form the goblet cells, and CDX2 gene begin to form the columnar cells. And these columnar cells can be of three types. These columnar cells can be of three types. What are those? One, they can convert the squamous cell into the columnar cell. This is one type. Another type, the cardiac columnar cells. That means the cardiac part of the stomach. These cardiac columnar cells, they grows up. This is another source. And then the third source is that in the cardiac part, we have the cardiac stem cells. These cardiac stem cells will proliferate to form the columnar cells, and then they finally grow into they replace the squamous cells into the columnar cells. Is that okay? So this is the pathophysiology. Look at here. We have the same mechanisms we have given over here. In this mechanism, you can see we have the reflux induced injury over here. This is the stomach cardiac part, right? So from the cardiac part, we can see over here, right? So what is shown over here? That is grown, right? So what is grown? Okay, itself, the stratified squamous epithelium itself grow and replace this the injured cells, right? So that this is the squamous cell itself grows to the columnar cells. They modify, they undergoes the adaptations, and then they replace these injured cells. Another source is that what they have injury over here, and you can see the cardiac columnar cells, they grow upward and then they replace the injured part. And then in the third picture, you can see over here in the cardiac part, we have the stem cells. These stem cells, they grow to the columnar cells and then they replace the injured parts, right? So that we have the three sources. Number one, same squamous cell. Number two, we have the cardiac columnar cells. Number three, we have the cardiac stem cells. They can replace to form the columnar cells. Is that okay? So this is the way how the Barrett's esophagus forms, right? So we know the pathophysiology. Now let's go to the symptoms. In the clinical presentation, the symptoms we can remember easily. The most common cause was what? The GERD. Show that the symptoms of the Barrett's esophagus is similar to GERD. So what is the symptoms? Symptoms is similar to GERD. Similar to GERD means what? Heartburn, right? And we have the epigastric pain, right? And patient may have the nausea or vomiting as well. The patient may have nausea and vomiting. If the inflammation is undergoing, then patient may develop the dysphagia or odinophagia, right? Odinophagia means the painful swallowing. Dysphagia usually indicates the complications as stricture formation. Is that okay? So if the patient with the GERD comes to you with the dysphagia, you have to suspect patient might have the complications as the stricture formations or maybe the adenocarcinoma development, right? So that we have to be careful on that. Okay, after this, and if you do the physical examination, in the physical examination usually patient is normal, so nothing is found in the physical examination. After that, let's go to the diagnosis. The diagnosis of the Barrett's esophagus usually is a clinical diagnosis. That means we see the history of GERD, right? So and usually it is more than 5 years, then we suspect patient has what? Barrett's esophagus. And in the some patients we have to do the screening endoscopy. Endoscopy is not mandatory always, because we can diagnose clinically and we can start the treatment as a prophylactic treatment, right? So that screening endoscopy is done in some of the patients. What are those patients? Number one, if the patient has more than 5 years of symptoms, right? Prolonged symptoms. Number two, Patient's age is more or equal to 50 years is patient, right? Number 3, the patient has smoking history. Patient has smoking history. Similarly, patient is obese. Patient is obese or obesity. Similarly, first degree relatives has esophageal cancer or stomach cancer. Then in this patients we have to go for what? Screening endoscopy. So these factors, they are called the alarming signs or alarming features of GERD. We have to remember this one. This is the question in the exam. So what are the alarming features? Number 1, GERD symptoms for more than 5 years. A patient's age is more than 50 years. Patient has smoking history. Patient is obese, or the first degree relatives has what? What is this one? The adenocarcinoma or the stomach carcinoma, right? So these are the screening for the endoscopy. And one thing we have to understand, endoscopy is always the diagnostic, the investigation of choice for the Barrett's esophagus. And what are the findings in the endoscopy? The endoscopic findings. We can divide these endoscopic findings into 3 different categories, okay? Number 1, columnar epithelium. Columnar epithelium. These columnar epitheliums, how do they looks like? Number 1, they looks like erythematous. We already discussed, right? Erythematous. And these erythematous epithelium, they looks like the velvet or tongue collar. Which color? Tongue collar. Is that okay? The tongue like the tongue like smooth. Is that okay? Or they are also called the salmon collar epithelium. Is that okay? So these are the erythematous, or what? The findings in the epithelium, erythematous or velvet or tongue or salmon color epithelium. If we see in the lower esophagus, that means this is what? Columnar epithelium. Usually the squamous epithelium of the esophagus, they looks like the pale or glossy. Glossy means the muscle, like muscle, right? Glossy. So this is the color of the squamous epithelium. Squamous epithelium. If it is columnar epithelium, it looks like what? Erythematous. These are the questions in the exam. So this is one finding. If it is Barrett's esophagus. Number 2, we can see the Z line. Z line. Is that okay? Z line means what? Squamocolumnar junction. What is the distance between the squamocolumnar junction and then the GEJ? That was our squamocolumnar junction. So this distance would be what? How much? This distance was we can say 0.321 centimeter. But if there is the Barrett's esophagus, then what happens? This squamocolumnar junction will shifted upward. So this squamocolumnar junction will present over here, so that this distance becomes more than 1 centimeter or more than 0.321 centimeter, right? This is one. Another thing is what? This squamocolumnar junction is regular. Regular means what? Like this, ring like. But if the patient develops the Barrett's esophagus, then this becomes irregular. This becomes what? Irregular. So that second finding is what? This distance increases and then the Z line becomes irregular. So these are the findings, okay, about the Z in the Barrett's esophagus. Another finding is that about the segment. If this segment involves about 3 centimeter, if this segment involves about less than 3 centimeter or more than 3 centimeter, is that okay? If it involves less than 3 centimeter, it is called short segment Barrett's esophagus. If it involves more than 3 centimeter, we say this is long segment Barrett's esophagus. Is that okay? Long segment Barrett's esophagus has increased frequency of adenocarcinoma or stricture formation. Is that all right? So this is the endoscopic findings, and endoscopy is what? The investigation of choice for IOC for the Barrett's esophagus. Remember, we can see in this picture, right? So in this picture we can say this is the normal esophagus. We can see the squamocolumnar junction probably over here, and we can see this junction, this is regular. Can you see this one? This is the velvet color or tongue color. Above this we can see this is the pale color, right? So this is our squamous epithelium. This is below, this is what our the columnar epithelium, and we have the regular margin. Is that okay? Now if we see this one, see, this becomes irregular. One island of squamous cell is over here, and then we have here the columnar epithelium. Similarly, we have all of these are the columnar epitheliums. This is the squamous epithelium. Again, we have here columnar epithelium. So it becomes irregular, and then we can see the length is also longer, right? So that this is our what? Barrett's esophagus. Barrett's esophagus. We can see the same picture over here. In this picture also, it is not much clear. We can see here we have some erosions as well, right? The ulcerations, bleeding points we can see over here. Yeah, and here we can see this is what? The columnar epithelium. Here we have the dusky as a squamous epithelium. So this is the finding in our what? The endoscopy. We can see a pale glossy as your what? The squamous epithelium. Otherwise we can see the erythematous, velvet or tongue like the what is this one? Columnar epithelium. Endoscopic biopsy. For the definitive diagnosis of the Barrett's esophagus, the only endoscopy is not sufficient. We have to do endoscopy with biopsy, and in the endoscopy with biopsy we have to take the 4-quadrant biopsy from each 2 centimeter of the suspected area. Is that okay? So from 4-quadrant means, for example, this area is my suspected area. I take the biopsy from 1 point, 2 point, 3 point, 4 point. That is called what? 4-quadrant biopsy. So in this 4-quadrant biopsy, what do we find? Our finding is 3 types of metaplasia. Metaplasia means the conversion of one type of cell into the another type of cells. Here what happens? Here we have the squamous cell is converted into columnar cell. That's what we call this as what? The metaplasia. So we have 3 kinds of metaplasia we can find over here. Number 1, intestinal type metaplasia. Number 2, junctional metaplasia. Number 3, gastric metaplasia. And how do we understand? All has columnar cells. All has columnar cells. It also has the columnar cells. It also has the columnar cells, right? So if it is intestinal type of metaplasia, there will be the columnar cells plus goblet cells. Goblet cells means single mucus secreting cells. Is that okay? So if we see this single goblet cells, we say this is what? Intestinal type of metaplasia. Another, if we have the junctional metaplasia, we will have what? If it is junctional metaplasia, we have the columnar cells with mucus gland present, right? Then we say this is a junctional type. If it is the gastric type metaplasia, we have the columnar cells plus foveolar cells, foveolar stem cells. You know, the foveolar stem cells means the gastric neck cells. In the gastric gland, there is a cell. If you remember the gastric gland like this, in the gastric gland we have the surface mucus cells, and then we have the foveolar mucus cells, right? So these foveolar mucus cells, they are also called what? Gastric stem cells. So that if we see these 3 kind of metaplasia, we will differentiate what kind of metaplasia is this: intestinal, junctional, or gastric. If it is intestinal, there is what? Columnar cells plus goblet cells. If it is junctional type, there will be columnar cells with mucus gland. If it is gastric type, there will be columnar cells with foveolar stem cells, right? So that these 3 kind of metaplasia we will see. Among these 3 types, the most common is intestinal type, and then this has the most common chance of adenocarcinoma. Remember this one. Is that okay? These are the questions in the exam. Wherever I say most common, these are the questions, okay? And this biopsy technique is also the question. These findings, whatever we discussed right now here, these all are the questions in the exam. Remember, is that okay? So these are the endoscopic biopsy findings, right? So we can see the goblet cells like this. They have shown over here. Yes, goblet cells. Goblet cells are big, you know, the white colored cells. they have multiple, the mucus filled granules inside, and then these are the goblet cells. Okay, this is the diagnosis. After diagnosis, we can go for the treatment. So how do we treat? In the treatment, we can categorize into different types. Is that okay? If it is non-complicated, you start with PPI plus, you can go for the lifestyle or diet modification. You can do, this is the treatment if it is non-complicated. If metaplasia is there but there is no dysplasia, right, in this condition what we can do is that we have to start with the PPI plus we can do the lifestyle or diet modification, plus we have to screen in every 3 to 5 years endoscopically. Is that okay? So repeat the endoscopy every 3 to 5 years. This is the second option of the treatment. In the third, if it is indefinite for dysplasia means high grade metaplasia, and it is, of course, if it will convert into the dysplasia in the future. If it is so, what we can do is that, of course, we have to do the patient's treatment. That is, we have to optimize the treatment. Optimize the treatment means here PPI and PPI we are giving OD once a day. Here we have to give the PPI optimize means BD, right? And then we have to repeat the endoscopy with biopsy in 3 to 6 months. Is that okay? To check either it undergoes the dysplasia or not, right? So this is the treatment, third option. And if patient has the already low grade dysplasia, for the low grade dysplasia, yes, of course we will give the PPI. PPI is mandatory for everyone. Plus, if it is already dysplastic, we can go for the endoscopic mucosal resection. Endoscopic mucosal resection. That means we can just insert the endoscopic tube inside, and then in the tube we can insert the knife, and by the knife we can just cut this mucosa and then remove this out, right? So this is the endoscopic mucosal resection. This is for the low grade dysplasia. If it is high grade dysplasia, of course we can go for the PPI. This is mandatory for everyone. And then we can go for what? What is this one? Radio frequency ablations. That is what? The radio frequency ablation. That means we can burn this by passing the electrocautery inside. Is that okay? This is high grade. And of course, if the diagnosis is unclear, that means in the endoscopy, if we cannot identify either it is a dysplastic or only metaplastic, or it is indefinite, or it is low grade or high grade, then always the safe choice is what? Resection, the mucosal resection. And we have a chart over here, the treatment chart. You can go through this, right? Okay, yes. So either you can start with the the S2 blockers, that means the ranitidine, like this type of drugs, or you can start with the PPIs directly, right? So if you start with the ranitidine twice a day, then you can just check whether the response is good or not. If the response is okay, you can continue that. If the response is not good, then you can change this to what? PPI. And for the PPI, initially you can start with the OD, then you can go for BD, and then accordingly you can go for what? The continuous follow-up, and then you can treat the patients accordingly. Complications of the Barrett's esophagus can be the Barrett's ulcer. Patient may develop the Barrett's ulcer. Barrett's ulcer means patient develop the ulcer within the Barrett's esophagus. Barrett's esophagus, that is called what? The Barrett's ulcer. Is that okay? And this Barrett's ulcer should be always what? Biopsied. We should always take the biopsy, because this ulcer may change into the the cancer. After biopsy we can do the resection. This is the treatment for the Barrett's ulcer. Is that okay? And this Barrett's ulcers, they may sometimes bleed, they may perforate, right? Perforate, so they may produce the another complications as well. Similarly, the strictures development. Sometimes the Barrett's esophagus, it may develop the stricture like this, and then causes the obstruction, partial or complete obstructions, right? So this stricture usually may be 1 to 4 centimeter long. So remember, if the stricture is long stricture and in the mid esophagus, it is always 99% chance due to Barrett's esophagus. This is a question exam. If there is a mid esophagus stricture which is longer stricture, right, usually 1 to 4 centimeter I said, then we should think that this is what, this is the Barrett's esophagus complications. Is that okay? And another complication is what, the adenocarcinoma. And about the adenocarcinoma we'll discuss, the increases the risk by how much, 40 times risk increases, and about 1/3 of the patient develops the adenocarcinoma. And every year, you know, we discussed already, 0.2 to 3% of the patients that develops the adenocarcinoma or the malignancy. So this is the about the complications. Hope you understand. Yes, so we finished the Barrett's esophagus, and all of those things, you know, they are very much important for your exams, for the MCQs. Whatever we discussed, all of those points, you know, they have the examination significance. So my advice is, please go through those this lecture once again, and then note it down. Yes, I checked my note while explaining the lecture to you, because I don't want to miss any points while you know, the explaining, because if I miss something, probably that will be lack for your, you know, the exam preparations. That's why I keep checking my notes, and then I just explain to you. Hope you understand. See you guys in the next videos. Thank